Thank you. Thank you, Jim. I just want to say what an honor it is to be on this panel. Dr. Molina, you were fantastic, and Dr. Valente, of course, we both use your work, so thank you for setting the course for us, and to Jim for being my postdoc mentor and also inviting me to this group. So I am Nina Yamanis, or my real name is Vespina. I'm Greek American. I'm an associate professor at the School of International Service in Washington, D.C. I also am the associate director of the Social and Behavioral Sciences Core of the DC Center for AIDS Research. And as Jim mentioned, I do work both with Latino, Latina, Latinx in the DC area, and also with youth in Tanzania. Today, I'm mostly going to talk about my work in Tanzania, just to kind of go in depth on one particular intervention, since Jim asked me to do like nuts and bolts of intervention work, so I thought that would be helpful. I want to acknowledge my partners, particularly at the Muhimbili University of Health and Allied Sciences in Dar es Salaam, which is the National Hospital, and National School of Public Health in Tanzania. And this R01 that I'm mainly going to talk about, which was the PI was Dr. Suzanne Maman, who's at UNC, who was my dissertation advisor. And I can just tell you, for those who are, early stage investigators, we started this work as my dissertation, then an R21 when I was a postdoc, and then an R01 my first year of being a junior faculty member. So like the work that you do in your dissertation can really take you far. Now I have an R21 of my own, so I think you can see the trajectory. I also want to acknowledge, like Dr. Molina said, that collaboration and community partnership are so important and critical to the work. When you find good partners, stick with them, because that's how you get things done. And also listen to your partners. So don't just come in with this idea that I'm going to do a network intervention and we're going to get it done. They are the ones who know the communities, live in community, be there with them. That's really the best. And this is just Dr. Kajula and I in Zambia 2 weeks ago at a Fogarty meeting. So we still see each other regularly. And she'll be here next year at UNC as a Fulbright. So if you want to get to know her. So just to give you a bit of context, I work Eastern and Southern Africa is the area of the world with 53% of the global population of people living with HIV. 60% of adolescents living with HIV live in this region. And in 12 of the countries in this region, HIV is the leading cause of death for adolescents. Women have higher rates of HIV compared to men, and it really is characterized by a heterosexual epidemic. So women are the ones that we focus on because they have 2 to 3 times the rate of HIV compared to men, and heterosexual transmission is what's occurring here. So I've really been driven by this work for a number of reasons, but I think Harling and Tsai's paper kind of encapsulates a lot of what drives me as well, and that those who are most in need of interventions are not able to access or use them. We need scalable interventions for people living in this region, in Eastern and Southern Africa. They have to be implemented at scale and have to be cost effective. At the same time, we know that social support and social norms flow through networks, and norms are really, I think, the biggest, stickiest challenge in Eastern and Southern Africa. Like, we're 40 years into an epidemic, and people are still not using condoms, still not HIV testing regularly, still intimate partner violence is a risk factor for HIV. So we have to do network analysis and network interventions because we need to change those norms. And they argue that SNA-informed interventions can be more effective and less unequal in their effects, both because they help us penetrate key populations that are hard to reach, but also because they can improve efficiency by maximizing spillovers, as Dr. Molina was also talking about, to at-risk individuals through their social ties. I'm also driven by work on peer and popular opinion leaders, which you'll see me talk about in this intervention. And just that peers can serve as a role model for behavior change. They can help their peers evaluate and make a decision to adopt. So we focus on this particular intervention on men, even though I told you that women have higher HIV rates. But men are really important in the epidemic because they actually control decisions that are made about sexual relationships. They often, make decisions about condom use. And violence against women is also a risk factor for HIV in women. But not only that, norms are, men are important for women's HIV risk, but men also are important for their own HIV risk. So young men in particular, tend not to go to the doctor as readily as young women. And in Africa, really, most of our HIV interventions are driven by prenatal care. So women get HIV tested when they go to the doctor, and men don't have that same entry point. So they have low rates of HIV testing, and this makes the consequences, they have premature mortality as well from HIV. So they get diagnosed later with HIV later in the course, and then die younger. So there's been really a call to engage men in HIV prevention efforts, but obviously finding them in a generalized epidemic is a bit of a challenge. And we're working in an area where Dar es Salaam, where it's the commercial capital of Tanzania. It's very populous, 4 million people, 70% of them live in informal settlements. It has the highest rate of unemployment in Tanzania and a very large concentration of youth. In Dar es Salaam itself, there's about a 9% HIV prevalence rate. So how do we find men in this context? Well, we used a methodology called PLACE, which was adapted by Sharon Weir at UNC. And it's really about finding venues where people socialize and meet new sexual partners. So the idea is that you're looking for places where risk behavior is occurring, not people. So it's really the idea that you're destigmatizing HIV by looking for a venue or a place rather than a person. So you first select an area where there's a high likelihood of transmission, then you go around and ask all the people in that area, where do people meet new sexual partners? And then you get a list. And from that list, you go and then visit those venues and you sort of verify that HIV risk is happening there. And then you can randomize those venues as well. So from that work, we found that there were places where young men socialize. They called them camps. And this is the Swahili word. That's what they call them. I do speak Swahili, but there's no translation. They call them camps. And these are actually sociometric social networks. So we were very surprised by this. We didn't know that camps existed in this context. A camp is kind of a cross between a club and a gang. So you have to imagine an informal settlement or a slum where youth don't really have a place to play. And so they decide to find a spot, like under a mango tree next to a house, where they can hang out with each other every day. And then they call that their camp. And they give their camp a name. So like one camp called themselves Al-Qaeda Camp. And this is Al-Qaeda Camp right here. They have no affiliation with Al-Qaeda. They just think that name sounds very powerful. And this camp is actually relatively well off because they have chairs and they have a roof, but not every camp does. The other thing about camps is members visit every day. They have an elected leadership. So they have a secretary, a treasurer, a chairperson. They have even a constitution. So like Dr. Molina was saying, communities already are doing things in some ways that we want them to do. They were quite large, so an average of 32 members, 85% of whom were male, and they had both risk and protective features for HIV. So what we ended up doing with the camps over several studies was thinking about how we wanted to understand more about how their networks influence their HIV risk behaviors. So from each of the leaders of each of the camps, we got a camp roster. And that roster included each person's name in the camp, their last name, first name, nickname, their age. And then during our surveys, each name would be read aloud by the interviewer. This was before Network Canvas, by the way. So we actually programmed this with a partner in India who programmed it. And the respondent is asked if they know the person, if that person is a friend, an acquaintance, or someone they don't get along with. We also asked for 3 closest friends, and then nominations to individuals who did not respond to the survey were removed from the analysis. And then we also, for the network dynamics studies, we calculated network dynamics using mean imputation measure for missing data. So we published a number of studies on how the social network, just in a cross-sectional sense, has influenced HIV risk behaviors, on concurrency, on HIV testing, and then on multiple behaviors, including IPV, with Marta Mulawa, who's here at Duke. And we've looked at like the close friends reports versus the actual reports. People don't actually know what their close friends do. They misperceive their close friends' behavior. And so there's an opportunity there to correct the misperception as well. So talking about the nuts and bolts of interventions, that's what I'm really going to focus on. So there were many opportunities for interventions in these camps. One is we know that they influence each other socially, and particularly for HIV risk behavior. We've shown that in multiple studies. They're stable venues. They have a natural leadership structure. And importantly, they also engage in business activities in which they support each other. So they help each other find work. Some of them actually have businesses themselves, like this tailor right here. So the R01 was a microfinance and health intervention to determine whether camps who were randomized to microfinance and health had a lower incidence of STI and IPV perpetration compared to men in control camps. Our secondary outcome was HIV testing, and so it was a randomized clustered design with network as the cluster, with 59 camps who comprised 1,249 men and 242 women. This is the conceptual summary of the intervention. So you can see that we hope that both microfinance and the peer leadership would give men more hope and future orientation so that they would be more likely to engage in HIV protective behaviors. We know that for many men in this setting, they don't have work, so microfinance was an opportunity for them to develop their entrepreneurship and business skills and actually try to have hope for the future. And we hope that that would then help them engage in less HIV risk behavior. But we also gave them peer leaders who would educate them on HIV prevention and talk to them about gender-based violence, which was another component of our intervention that ended up being more difficult for them, talking about gender-based violence versus talking about HIV testing and condom use. So one thing that you have to think about when you do network interventions is how are you going to control for contamination? So we had 205 eligible camps. They were in 4 different wards of Dar es Salaam. So we ended up clustering them contiguously, and then each cluster became a unit. And then we randomly picked the cluster, and then one camp within the cluster was selected for intervention or control, and they were spread apart. That's how we spread them apart geographically, and that's also described in this paper here. We did baseline and network assessments at 3 different waves. So we have longitudinal sociometric network data at 3 waves, and we have both biological assessments at baseline and endline. So because we talked a lot about popular opinion leaders, I thought I'd focus on that. I can talk about microfinance, but that's probably not as much of interest to this audience. But anyway, we had 170 health leaders who were nominated by their peers. So this is one area in which I diverged from Dr. Valente's recommendation, but my community partner really wanted us to go through this process of the camps themselves nominating the peers who would then get trained to deliver health education. So we couldn't do like a between-us centrality or in-degree centrality, although we did look at it later, and those with higher between-us centrality ended up having more conversations about gender-based violence. So there was something there. But they nominated them. Those leaders were trained for 1 week, and then they received 2 boosters, and they received an extensive training on HIV and on how to talk to their peers about HIV prevention. So just as important is their confidence in talking to their peers, right? And like how to deliver those messages, especially about things like gender-based violence, which are so normative in society and kind of taboo in that society. The other thing we did, which we wrote a paper on, was how do we talked about retention strategies for these leaders. So this was a 2-year intervention. It was a long time for them to stay engaged in being a peer leader. So we offered them, for example, the opportunity to participate in the CAB meetings. We did a hip hop session with them from a professor here at UNC and then another professor at Duke whose expertise is in hip hop. They developed prevention t-shirts and slogans. And then we also gave them booster training to deal with challenging conversations. So for example, this young man, Osama, he was trying to get his cousin to HIV test before she got married. and they had a community meeting about it, and everybody started yelling at him when he said you should HIV test. And he was kind of ostracized from the meeting, and then later the man she was gonna marry actually took off. He wouldn't test. He talked to his cousin privately, and later it turned out that that man was HIV positive, and she avoided actually getting married to and his former wife had died. So in the end, everybody was saying, Osama, you're a savior, like how did you know? Whereas in the first instance, they had sort of ostracized him. So dealing with those kinds of challenges are really important, and staying in touch with peer leaders and understanding what they're going through during the process is an important part of intervention implementation. We also asked them some things like, we were talking about yesterday, like how do you measure or how do you understand sort of the ethics of intervention? So we asked the leaders, do people believe in you? Do you think you're more skilled, and do members of your camp respect you? And so most of them said they strongly agree, but just even measuring things like that can help you with understanding what's happening. We also asked them, you can look at network measures, but you can also ask them, in the past 12 months, how close have you become? Have you become closer? And they said, most of them said, yes, we've become more close, 87%. And then, was this because of the study? Yes, 87%, yes, this was because of the study. So just showing that they appreciated the study. So in terms of results, men in the so this is the paper, but we didn't actually see a positive result on our primary outcome, which was STI incidence. We didn't reduce STI incidence. We also did not see a positive result on perpetration of gender-based violence. Unfortunately, we did see an increase in HIV testing in the intervention arm and a decrease in gender inequitable norms. So they became more equitable in their norms towards women. And that is a precursor to IPV perpetration, so you can think of it that way. Obviously, changing these norms takes a long time and investment, and the leaders felt less confident at sharing messages around gender-based violence, so perhaps that just didn't work as well. The other thing that I'll just mention quickly is that the microfinance piece did not work very well. Only 26% of the intervention participants actually took up microfinance, and so what we had hypothesized to happen really didn't happen. And we tried everything. We tried so many different things with microfinance, and young men need longer time periods. They need more mentoring in microfinance. They need better skills training in this setting. Those were the conclusions that we came up with. But just to round this out, I wanted to talk a little bit about how we use the network data. And this was really to understand mediation and what happened, particularly with respect to HIV testing. And just a few of these studies have been done in Africa to understand really network effects during an intervention, so we thought it was an important opportunity. And we used stochastic actor-oriented models to simultaneously estimate the evolution of the network dynamics and the behavior dynamics during the intervention. And these are amazing models. David's going to talk about them tomorrow, because they can control for any endogenous network mechanisms that may be happening during the intervention that would induce similarity on friends' behaviors, and then they can also estimate the peer influences that's happening. So this is work with Brian Aronson and Jim Moody. Brian I met through this workshop, who's amazing, we also presented at SAMC a couple years ago. The paper's not out yet. So we used RCNA. The only thing about RCNA is that it's highly sensitive to heterogeneity across network contexts, missingness, network instability, and overly small network size. So sometimes really hard to use depending on your networks. We did look at both wave 1 and wave 2. We found density, reciprocity, and transitivity were pretty similar across the waves, so we felt okay about this. And then these are just some sociograms of our camps, and you can see that they're pretty diffuse, they're non-hierarchical, there's no one node that has all the nominations, and then the darker dots are HIV testing. So these are the steps, which I'm not gonna go over, but basically you have to go through the selection side of the model and then the friendship side, and then make sure the model that converges, and estimate goodness of fit statistics to make sure it fits the data. And so this was our final model, which just showed that There was a significant effect of the behavior dynamics, the social influence on HIV testing. So individuals did change their testing behavior to align with their friends' behavior. We also found an effect of health leader in wave 1, just suggesting that health leaders were more likely to change their testing behavior at wave 1. So it kind of shows that the intervention likely waned over time. So shorter interventions may be better. So finally, our results demonstrated that social network influence was responsible for the trial's efficacious effect on HIV testing. In other words, peer influence did mediate the effect. But the camp health leaders demonstrated change earlier in the intervention, as I said. Just to end with the fact that I'm taking this work and translating it to out-of-school adolescent girls and young women. So one thing that you may not know, but is that there's a huge program called PEPFAR, President's AIDS Program for AIDS Relief. It's done a lot of work with the DREAMS intervention in Southern and Eastern Africa, which is a huge intervention, but it mostly reaches in-school girls. And in fact, several studies have shown that it kind of does not do very well for out-of-school girls. So we're using the networked approach to try to find out-of-school adolescent girls and young women. They actually have networks too. They don't call them camps. They're smaller. They're only about 13 people instead of 35 people. They don't give them powerful names like Al-Qaeda. But the baseline HIV self-reported positivity rates among our sample were 12%. So these are girls in high need of PrEP and high need of HIV prevention interventions. And I'm happy to talk about that with anyone. Future directions, network analysis can help us understand mediating social mechanisms through interventions, so I highly encourage you to use it. Using peer networks is great for reaching underserved populations, like several that have been talked about today. But I want to just caution you that something that I've come up in review panels at NIH, thinking about scalability, that reviewers really want to know, is this a scalable method? And one thing that I've said in my work, or have had to say, is networks are being used to recruit and retain participants, but network analysis is not necessary for the scale-up of this intervention. So network analysis can help us understand what's happening, can help us understand the effects. As researchers, we're interested in network analysis, but if USAID wants to take up this intervention and scale it up, they don't need to do network analysis. We're gonna prove those things for them first. So just some more things for you to think about. Asante sana, thank you, gracias.
Thank you. Now what we're sort of hoping would happen would, we have these 3 leading experts in the world on health interventions, and so we know that many of you have burning questions on how to do this well, and so we're going to just open the floor and see where folks are at. So. I probably should have put a table up here with some chairs or some such. I don't know if you want to stand up here in the firing line or... But I'll let you field your own questions, or I'll field them and we'll just run it, please.
Well, I actually have a question for Nina. So I know in Vietnam they've found that with HIV, there was reduced adherence to medication as well as having home visits because of stigma and shame.
Yeah.
I don't know what the actual post-diagnosis treatment looks like.
In Tanzania? Yeah, they have access to...
That, like, how did they conceptualize HIV status? Like, was there like that heavy shame? Were they like not seeking diagnoses? Because I know, like, at least in the United States, I've seen this a lot with like STI diagnoses and whatnot, or even cancer. Sometimes you're like, well, if I don't get diagnosed, I don't have it, or I don't have to deal with it. Did you have any experiences with how they conceptualize HIV?
No, we were actually really surprised at the HIV rates, and we finished data collection right before COVID, and then Tanzania had a denialist president, and it has been a long, complicated way back, but he died of COVID. So, yeah. The new president accepted vaccines and so on, which I've written about as well. But anyway, so I haven't done as much work to understand the young women in our cohort, their perception of HIV, but it is very normalized to some extent, and people do have access to medications because of PEPFAR. So I think like 76% of people are on ART in Tanzania who need it, which is pretty high. I think for like many of the communities that we work with, for them, the more important thing is having a job, having a hope for the future, and so on. But yeah, we'd like to do more work on that in the future to kind of better understand their perceptions. Yeah. The other thing I should say though is that women are highly stigmatized around HIV. So in the sense that women are the ones blamed for bringing HIV to the family. And there have been some reports in Kenya that women won't go for antenatal care because they're afraid to get an HIV test, and they're afraid that it'll be positive, and then the family will ostracize them. So, yeah.
Please, sorry.
I have a question about sustainment of this awesome work. So I really appreciate the partnership with the community, and I assume that that's going to help with sustainment. But once the funding is gone, what do you guys, what happens to, in a lot of cases, the sustainment of this awesome work? And do you have any technical solutions for that or ideas?
I mean, I can start.
Go and pass the mic around. That's useful for us for the recording.
Yeah, I'm a monster. I'm sorry. I forgot the recording. I think part of what I've been advocating for the Empower model is that these network effects are sustainable, because what we're doing is trying to shift what we tell patients, right? And using that work, but then the network effects and what they propagate, we're not necessarily paying patients to then engage their family and friends. We're giving them the tools to do so, which helps. The thing that I advocate for at a policy level is, as we know, a number of payers have started to do reimbursements for preventative health, right? So sometimes your insurance company will pay you a little bit for a certain amount of physical activity or for certain weight management and things like that. And something I want to advocate for is that we expand that model, right, of us incentivizing health in terms of doing health coaching and things like that. But yeah, I will end there. But I think I will also just throw out there the programs that we have, a lot of them are already in place. So when I came in, that leadership model was already there. We just changed the community, the population that was there, right? So I think for me, it's build a partnership and recognize that all of your work should be built on what has already been there, and you're expanding on it. You're not asking them to do something totally different. You're building on that in a way that they can sustain without you, right? If you're gone as an academic partner.
Yeah, I'll just add that finding funding wherever you can. So I've received some funding from Fogarty, small grants, because I'm part of an alliance for implementation science in Fogarty in Africa. And then I'm part of the CFAR, so work with La Clinica that I do locally in DC. We have a community research scientific interest group and we got a supplement grant last year to do a little bit of work. So just trying to sustain when the big grants don't come through, I think is important. But just also sustaining the partnership in whatever way you can, I think is important as well. And then disseminating your work so that right now with the adolescent girls, we're looking at the Tanzania's National Social Protection Program and trying to emulate their model so that they might take up whatever we find and scale it up.
And I'll just add that generally network interventions are quite sustainable because you've already empowered people to do things. And we may be gone and we may no longer be documenting it, but those folks are still there, right? And they're still doing it.
Yeah.
Please.
You guys used to make comments to talk a little bit about ethics and network interventions. Could you talk a little bit more about that? I guess I'm trying to wrap my head around it being unethical because interventions are supposed to change people, right? It's change or whatever, they're supposed to change networks, I guess. Yeah.
Right, I know.
Could you repeat the question?
Didn't hear the question. The question is, can you talk a little bit about the ethics of these kinds of network interventions? Because we are making changes to networks, so we're intervening on them.
Yeah, you can also answer. I mean, so the work that I presented a little bit on beneficence and was funded by the Fordham Ethics Training Fellowship, which is just so fabulous, and they helped me, push me to think about it. So we also asked them questions like, did you feel the intervention changed you or your friend changed you? And a lot of them said my friend changed me, for the better. So asking those kinds of questions, I think helps get to the ethics. We did have a camp that totally dissolved where the leadership
collapsed, you know, and we think it probably had something to do with our intervention, like we were working with one leader who then people didn't trust, and so there are some ethical, you know, that can dissolve. Essentially, we dissolve the network. But whether that would have happened anyway, we don't know, you know, and I think it's just important to monitor these things. And then we're still in touch with a lot of these camps, so they tell us what's happening, and half of them ended up forming a new camp, going to another camp. So I would just say monitor it, but Dr. Valente probably has other ideas because he's written on it.
No, I think you have more experience than I do in this, and I do think we have ethical responsibilities to monitor this stuff, but we also have an ethical responsibility to use our tools to do good. You know, instead of always focusing on, well, maybe we did something bad. Well, bad things are happening all over the place all the time, and we have an ethical responsibility to do good by our communities. And I think not doing these interventions is ethically and morally irresponsible.
Yeah, I want to just add to that. I think that when doing these trainings, always offering an opt-out option and then also doing continuous assessment, like how did it go, what's going on, is really helpful. Something we do a lot with the programs and the community partners that I work with is really emphasizing this is a labor of love, you know, like being an agent of change is not something that's going to be easy all the time, and just providing some resilience and some supports and ideas, and then being empathetic if people choose to take a break and all of that. And I think that opt-out and that compassion in terms of whatever behavior they provide, being okay with that and being a trustworthy source, so they can trust you and maybe resume the manual, maybe do what was good for them and then move on. But I think just being accepting and understanding of that.
Yeah. So this is kind of maybe a more ethical question, or just like a situation, but like kind of going back to the diffusion of innovations, what if there's something like you're doing a group intervention among participants? What is the ethicality of inserting actors that talk about like implementing these interventions and having positive successes in that, and using those positive successes as like the early adopters to basically gasoline on the fire to spread like I guess that's a terrible analogy, right? But to spread you know, your messages and like say empower them to do that.
Yeah, I mean, I think public health does that all the time. I mean, you know.
Yeah, I can talk about it, and Nyan can also talk about it through the intervention that she's leading in terms of Bridge and Friends. I think what we've seen and what we start our community health workers oftentimes start with the success stories, right? So a lot of those phone sessions start off with, here's what happened when I was diagnosed with breast cancer, which is why mammography is important, but then here's how I started talking to my family and friends. I was really scared and all this positive work happened, right? I think what has worked equally well with the success stories is acknowledgement of the not great success stories. Kind of turning back, being fully honest and creating a space where we can be like, my neighbor just did and did ignore me. I was left on red on this text message, and providing that space wherein like there's successes, there's also challenges, I think in some ways is truly impactful. It's just being authentic, right? That it's not always going to be a success. We treasure the successes, and we sit with not successes in that way.
I'll just also add that we typically implicitly think about diffusion theory as the mechanism by which all of this is working, but we oftentimes don't measure that explicitly, right? And so, you know, I'm a huge fan of diffusion models. I love the precision that we can get from them, but we don't oftentimes record that kind of information, and we don't trace it in a purely diffusion model. And that has frustrated me for decades, because I thought with the advent of social media, we're going to have network diffusion models like crazy. I am still going to be famous. But it hasn't happened yet. Yes, Allison.
All right, I guess more for you talking about the spillover effects, and especially if you have an egocentric network, how are you capturing, is it them reporting on who I talked to, do I think they got a mammogram, or is there any other way to get at the spillover effects?
Yeah, that's a great question. So what we did in the K was definitely do kind of just self-report of the network member. Then what we did for the R21 is we engaged a sample of the family and friends and did a concordance score around it. And we compared and contrast, like, you know, you would assume, right, if they're reporting more, is there more social desirability bias, right, among navigated participants versus not? There's no significant difference. There's I would say about a 48% concordance rate in some cases, which is not a great rate, right? But we can account for that, and that works. I think the other thing that we're now working with, or an idea that we're spilling over, is kind of leveraging the ecological momentary assessment techniques that exist around, because, a lot of times I will tell you, it's not necessarily that people are trying to over-report on network mammography, they just not know about the network mammography, right? And so how do we do a tool that they could report on the spot when they engage the network member, and then when the network member can say, yes, and here's where I did it. I think the other thing that has worked really well in terms of network instruments that I've used is environmental strategies, just to align people back into that space as to what that conversation was like. So we often say, how many people, of course, name a few of them, but then tell us where you were. Were you on the phone, were you not? Tell us what you said. And I think bringing that in helps a lot with the recall challenge with it, and doing that with the network member as well, so that we can really get some accuracy, right? So where did you get your mammogram? If you don't remember the date, what was the bus line you took in doing that work?
I think we had a question in the back, maybe. I'm not sure. Did you have a question?
Hi. So you all kind of alluded to this, but I was wondering, networks are fluid. And so a lot of times the folks who we recruit as opinion leaders or as interventionists might leave the networks. They might be ostracized from the network, as you've all pointed out. And I'm wondering if you can talk a little bit more about how you sort of maintain the effectiveness of the interventions with the recognition of the fluidity and the ways in which being an actor of the network might then lead you to not be in the network anymore.
Sure. I can start the ball on that. I think that a lot of what we've seen, and I'll give you the positive and then I'll give you the negative. A lot of what we've been seeing, what we're hypothesizing to really quantify in the RO1, is that the individuals who start out relatively isolated, then because they have that strong relationship with the community health worker, they start volunteering, and their network actually expands, right, in some ways. Is it temporary? We'll find out in the R1, we're going to do some longitudinal tracking, we'll see how it goes, right? So I'm going to throw that one out there. I think for me, and this is my bias, right, in terms of collecting primarily egocentric data, is that network shifts don't necessarily impact the effectiveness for me as much, right? And so the idea is you might shift the network, but if you have that recognition and that training of being a leader and promoting that, even if you shift your family and friends, you are still an active change agent in that. And I think that's just something for us to think through, right? Because we constantly talk about bidirectionality. Networks affect us, we affect networks, but oftentimes we're modeling network affects us, but we're not talking about our impacts on others, right? So.
Yeah, I mean, I think it can be very challenging with using longitudinal data. And if your networks are changing, I mean, you may not be able to run those. I don't know. David's going to update us on the David Schaefer on the RCM tomorrow. But yeah, I think monitoring it and then choosing your networks wisely. Like, have they been? Are they pretty stable? Like collecting that kind of preliminary data in the beginning to know, how long have they been network members? Are they we also ask questions like, are you planning to leave in the next year? And then they would be excluded based on that. And then really making sure that you're tracking people and like we hire a whole full-time tracer, to go after people and making sure that we have all the data to contact them in the future so we can find out why they left, or if it was an ethical violation, for example.
And I also, in a lot of my work, don't see a ton of network change, right? I mean, people are relatively stable in their relationships, particularly in underserved and resilient communities. And then we also know that actually, and David again will help us on this, but according to Tom, you can have a fair amount of network turnover and still estimate Sienna models. Like you can have 50% network turnover and still, as long as you captured the whole network. Yeah.
Right.
Yes.
That was wonderful. Thank you so much for sharing your expertise. One of the things that jumps out at me when we talk about network interventions is that typically we're talking about going in and doing some exploration and designing an intervention and implementing it and seeing what happens. But in my field of public administration and policy, there's a saying that practice brings ahead of academia. And so out there, as Yamile said in her presentation, there are a ton of folks who are already doing
what, a program or what a state is deciding to do and seeing what happens later. So there's much less control over the outcome.
So the question is that practice oftentimes precedes policy, and that there are things going on out in the field that are ahead of what we're doing, and they're not necessarily running an randomized controlled trial in order to test those effects, but they're just doing them. And I actually have an apocryphal story around that very issue. In the mid-90s, I started working on network interventions, particularly the peer opinion leader model, and I was visiting my brother who was running 15 restaurants in Atlanta. And he goes, "Whoa, that's a great idea, this opinion leader thing. I'm going to use that." Because they're constantly, the wine list, and all these are high-end restaurants, the wine list is always turning over, and so they have to constantly train the staff on the wine list, on the offerings and whatnot. And so he would just go in and start asking all of his staff, so who's the best person that's going to teach everybody, right? Now, did he do a randomized controlled trial? No. Did he collect data for me? No. Did I get a cut of the proceeds? No. Nothing, right? But it's all out there in the field happening. And in business, this happens all the time. Pharmaceutical companies are using network data to find peer opinion leaders to push their drugs and therapies all the time. I mean, to the tune of billions of dollars, right? So there's a lot that's happening out in the field that is not being documented by us in the academy, unfortunately or fortunately. So when we talk about this in business settings, it resonates really, really well. They're like, oh yeah, we do that, not quite as, rigorously as you do, but they don't have to accumulate evidence and publish it in the journals. They just worry about the bottom line and doing what they need to do.
I also think of your work on the FCTC, the
FCTC,
Framework Convention on
For
Tobacco.
tobacco.
I mean, that was sort of a natural following a policy on tobacco.
I think the
Global spread.
And just building on that, I think using different words, right? So the word network, right? I don't know that most practice people who are doing network interventions are using the word network, right? So a lot of this is leadership models, leadership trainings, a lot of workforce investment in practice in hospital and healthcare settings where they're doing exactly what Dr. Valente said, right, in terms of how they identify the network, the opinion leaders in groups, and kind of build on that way. So we could maybe talk offline, but I just feel like there are keywords that are network-esque, and we just got to get that language in there.
Elizabeth.
Do you guys know of academics who are taking that next step and creating tools, network intervention tools and then testing them using rigorous, study, and then launching companies based on these tools and having this hybrid situation in the academy where you're a scholar and also a business person? Is that a viable path, or do you guys think that's a risky path, or do you know people who are doing it?
So I try to state the question, are there people out there that are on the cutting edge of this stuff and creating tools and implementing them in the field and sort of bridging that academic industry partnership gap? And I would say the people that are doing this to some extent are the Ron Burts in the world, who and the Paul Leonardis, who embed themselves in organizations and do a lot of work with them and understand what they're doing. But I will tell you, I've done a bit of consulting to both industry and organizations and for pharmaceutical companies. And they love this idea, right? And we'll present the data to them, and then they'll just continue doing things the way they've always done them, It's very hard to get the adoption of, say, an opinion leader intervention, even when you're going to the opinion leaders. And so, when we published our paper, what year was that? I think it was 2010 or 2011. We did an analysis of physician networks in 3 cities: San Francisco, LA, and New York, right? And we had collected network data. We'd worked with the pharmaceutical company, so we had a trace on exactly when the physicians adopted this new therapy that had come out. And we published the paper, and our industry partners goes, "Wow, this is really cool, man. it's amazing how quickly this happened. And I said, yeah, when I finished my PhD in 91, my goal and intention was to replicate the Coleman, Katz, and Menzel data that had been collected in 1955, right? So yes, it only took 20 years, right, for that replication to happen. So these things move at a glacial pace, unfortunately.
One thing I would add is that there is a dedicated funding mechanism for researchers to work with small business folks. So this is not like the NIH and NSF both want, because Congress wants to start businesses, so they both want to fund this kind of work. So if you're out in the world and would like to do this, there's opportunities.
Yeah, the SBIR mechanism, right? Yeah, and I've worked with MD Logic to do this. We've got a tool that's out in schools to combat bullying and victimization. Yep.
I would just,
I would just add, and this gets back to the earlier comment around certification for community health workers and navigators, which to me I identify, right, as opinion leaders are naturally in there. So we now have over 10 states that are doing statewide implementation of these opinion leader interventions where they're relying on grassroots organizations. I think there's a lot happening in nonprofit and government interactions in the programs and adopting it. Here are the challenges. They're not collecting the network data. They're implementing the interventions. They're not collecting the network data to actually demonstrate how great and how much better their reach is because of that. So that's part one. And part two, I think, as was mentioned before, the private sector is interested and excited, but kind of looking in my mind as to what CMS is going to do, to be like really honest. We're talking about health, right? For like reimbursements and things like that. So I guess I would just throw out there, I think there is some scaling that is happening right now and it is sustainable. The challenge, I think, is the different languages that are happening around that. They're just sparking these missed opportunities, right, in that space.
All right.